Hello everyone. Today we will discuss the latest guidelines on allergic bronchopulmonary aspergillosis, that is ABPA. So this is recently published in European Respiratory Journal. So this is by International Society for Human and Animal Mycology, that is ISHAM. So I will go to the summary slides. The first thing for diagnosis of ABPA, they have recommended there should be few criteria. One is predisposing condition, second is essential components, then other comments. So what are the predisposing conditions which should be there during ABPA diagnosis? So the first and foremost is patient should have an asthma or cystic fibrosis or COPD or bronchitis or compatible clinical radiological presentation. That includes what are the clinical radiological presentation which is compatible with the ABPA. The expectoration of mucus plug, finger in glove appearance or fleeting shadows in the X-ray, or lung collapse due to mucus plug, and other clinical features. So these are the predisposing condition which is needed for diagnosis of ABPA. So if patient is having asthma, the next thing the patient should have these two important things, that is Aspergillus fumigatus specific IgE more than 0.35. So this is very important. If the patient is not having this Aspergillus specific IgE, then we can take skin prick test also as an alternative, and the patient must have serum total IgE more than 500. So initially it was 1000, now they have recommending only 500 international unit. And in case of patient is having clinical symptoms, even if all other criteria are met, then even if it is less than 500, we can consider as ABPA. So these are the essential components. So first predisposing factors, then essential components, and any two of other components. These are three things. One is positive Aspergillus IgE. So IgG against Aspergillus. Blood eosinophil more than 500. This can be at the presentation, or we can just check the previous values if it is more than 500. So these are the two components. Now the third component is CT scan, thin HRCT or thin section of CT chest, which shows bronchitis, mucus plugging, and high attenuation mucus, or fleeting opacities on chest X-ray, which is consistent with the ABPA. So predisposing factors like asthma, COPD, bronchitis, cystic fibrosis. The essential components are specific IgE and total IgE. If it is then any of two, that is CT we usually do if there is bronchitis. They are not mentioning central or peripheral now, they are just mentioning bronchitis. And positive specific IgG or blood eosinophil more than. So any of the two. So based on that we can diagnose Aspergillus, that is ABPA. So some thing IgG can be different in different population. So Indian population, they have mentioned in India, Japan and UK, the value cutoff is different. So we have to use population based cutoff. And very important, this high attenuation mucus is pathognomic of ABPA and confirms the ABPA even if all other other criteria are not fulfilled. So this is important recommendation. So this is how we diagnose Aspergillus, that is ABPM. Now they have the recommendation for ABPM, that is allergic bronchopulmonary mycosis. So this all almost same to the ABPA diagnosis. Predisposing factor should be there, essential components are there, and the fungus specific IgG should be there. That is, if it is like for any other Aspergillus species or mucor like that, we should have that specific IgG. Then one more important thing they have recommended is 2 sputum sample or 1 bile that grows that causative fungus. So it was not there in ABPA diagnosis. So if we see that ABPA diagnosis, it was not mentioned for that one, and in here it is mentioned 2 sputum or 1 bulk sample in that matter. So that is how we diagnose ABPM. Now coming to the next important slide, how we diagnose, how you the workflow for ABPA diagnosis. So if your patient is having predisposing factors like asthma, COPD, bronchitis like that, then we have to do seek IgE. They are recommending specific IgE first. If it is more than 0.35, then we have to go for serum total IgE. If it is more than 500, then we have to do blood eosinophil count and aspergillus IgG. So if we do the aspergillus IgG, then that also positive, then we have to do CT scan. CT scan pattern that are mentioned like 1, 2, 3, 5 pattern, that is ABPAS if there is no bronchiectasis, ABPAB if there is bronchiectasis, ABPAMP for mucus plug, HAM, ABPA HAM, and ABPA with chronic pleuropulmonary fibrosis, that is IBPA CPF. So these are the 5 category based on the CT scan. If all these things aspergillus specific is negative, Ig is negative, then what we'll do? Then we have to do the sputum culture. If it is any other fungus other than aspergillus, then we have to do the IgE, the eosinophil counts, fungus specific IgG, and the abnormal CT. Then it comes ABPM. So these are the 2 ways how we diagnose the ABPA and how we classify. These are the recent recommendation. Now coming to the just radiology they have mentioned in their presentation. This is ABPA without bronchiectasis, then with bronchiectasis, and with mucus plug. You can see the mucus plug both lung window and mediastinal window. Then this is the high attenuation mucus. So if we compare with the paraspinal muscle, the attenuation is high, that is high attenuation mucus. This is the lung window for that. Then chronic pleuropulmonary fibrosis, sorry. So this is the CPF, ABPA CPF. You can see the pleural and pulmonary fibrosis here. So now the next thing, the criteria for different stages. So now they have changed to 5 stages, that is acute ABPM, treatment response, remission, treatment dependent, and advanced ABPM. So what is acute ABPM? So newly diagnosed patient with ABPM, so if they have exacerbation, that is patient should have diagnosed with ABPA and they have 2 weeks of clinical worsening, radiological worsening, serum total IgE more than 50% from the value which was during the clinical stability, and we have to rule out other, like patient having asthma. So if you have to rule out asthma exacerbation without any radiological deterioration, and bronchiectasis exacerbation, that is with cough, sputum, spulency, fatigue, fever, hemoptysis, and without radiological or radiological deterioration. So the thing is, patient should have symptoms more than 2 weeks, and additionally radiology there should be worsening, which is usually there is not known in asthma, and the serology also should be 50% more, that is serum total Ig should be more than 50% from basal value. Then we say as acute asthma, acute ABPA, or exacerbation of ABPA. Now coming to the response, and then we have starting on treatment. If the patient have acute improvement symptoms, that is by 50, at least 50%, that assessed using Likert or visual analog scale, and 50% reduction in the radiological response, or decline in serum total Ig by 20% after 8 weeks. So we have to see the response after 8 weeks. 8 weeks means 2 months. So 2 months we have to see the patient response. Clinical response 50%, radiological response 50%, and serum total Ig response 20%. Then we say it as response. So when we will say it as remission, if there is more than 6 month clinical and radiological improvement and patient is off steroid. So patient, we have stopped steroid and patient has stable more than 6 months and that there is no rise in serum total IgE. So this is the simple thing of steroid. Patient, even the patient may be on biological or antifungal, may be considered as remission if they meet the above criteria. So patient off steroid more than 6 months and clinical radiological improvement is sustained, then it is remission. Now coming to the next thing, treatment dependent ABPA. So in which within 3 months patient have two more exacerbation of the ABPA and within 3 months of stopping steroid. So whenever we stop steroid within 3 months patient get 2 exacerbation, then that is known as treatment dependent ABPA. So it is very specific things. 3 months we had to see stop the steroid within 3 months, 2 episode of exacerbation, then treatment dependent. And for that, whenever there is worsening symptoms and worsening of radiology and rise in serum total IgE by 50%, while we are trying to taper the steroid on 2 separate occasions. So there are 2 definitions. We stop the steroid and we within 3 months patient get 2 exacerbation. We try to taper the steroid, then the patient have the respiratory symptoms and radiology worsening and rise in serum total IgE more than 50% within 4 weeks of tapering on 2 different occasions. So this is treatment dependent ABPA. Advanced ABPA, if the patient have extensive bronchitis more than 10 segments and patient develop core pulmonary or type 2 respiratory failure, this is advanced ABPA. So once again, acute ABPA exacerbation, if the patient have more than 2 weeks of symptoms with clinical worsening and increase in IgE by 50% from baseline. And we have to load asthma exacerbation and bronchitis exacerbation. Then treatment response, patient we have treating for 8 weeks, clinically 50% improvement, radiologically 50% improvement and 20% decline from serum total IgE. Remission, patient off steroid and patient have more than 6 months clinical and radiologically patient is stable. And if we are patient is lack of rise in serum total IgE more than 50% from the last recorded clinical stability, that is remission. Treatment dependent, if we try to stop the steroid within 3 months patient have 2 exacerbation, or while we tapering the dose of steroid patient have clinical radiological worsening along with 50% increase in the serum total IgE. And advanced ABPA when the patient is having core pulmonary or patient is having chronic type 2 respiratory failure. So these are the few important things we have to check when after diagnosing the ABPA. Now, what are the treatment options? Asymptomatic patient, there is no role of treatment. We have to monitor patient clinically, radiologically, and in between we have to do every 3 to 6 months serum total IgE also. If the patient has ABPS, if there is poor asthma control and patient have recurrent exacerbation despite of asthma treatment, then we have to treat with systemic steroid. There are 2 doses they are recommending, that is low to moderate dose, that is 0.5 mg per kg per day for 2 to 4 weeks, then completed under 4 months, or itraconazole for 4 months. So this is initial treatment for acute ABPA. So when the patients when patient has contraindication for systemic steroid, then they have recommending oral itraconazole. And combination of itraconazole and steroid as a first line therapy, they are not recommending. So, however, if we are using oral itraconazole, initial 2 weeks we can use glucocorticoids. And the second line antifungal like voriconazole, posaconazole, suvaconazole, they should not be used as first line. If there is failure of steroid or failure resistance to itraconazole, then we can use oral voriconazole. And high dose should not be used as a primary therapy. You may use as a secondary therapy, but not as a primary therapy for acute ABPA. And biological also not recommended as a first line treatment for acute ABPA. So once again coming to the slides, high dose inhaled steroid they are not recommending for primary therapy, and oral steroids are the most rapid acting for acute ABPA. Oral itraconazole, voriconazole have similar efficacy with fewer adverse effect, but thus we have to use itraconazole. This has steroid sparing affecting treatment dependent ABPA. And if patient is not responding to itraconazole or voriconazole, then we have to consider oral posaconazole. Omalizumab reduced asthma exacerbation and also steroid sparing action in treatment dependent ABPA. This has grade 2 recommendation. Other biological like mepolizumab, benralizumab, dupilumab and tezepelumab, they have steroid sparing effect, that is level of evidence is grade 3. Nebulized amphotericin may reduce the number of asthma exacerbation, ABPA exacerbation, and increase the time to first ABPA exacerbation when used as therapy, maintenance therapy in stable ABPA. And acute exacerbation should be treated as newly diagnosed ABPA, and a combination of oral prednisolone itraconazole should be used for treating recurrent ABPA, that is patient with recurrent exacerbation. And biological agents or nebulized amphotericin, they are not used in acute exacerbation, they are only used in stable patient. So this is the summary slide. So first we diagnose ABPA, then we have to give oral corticosteroid, that is itraconazole or oral corticosteroid. Then we have to do follow-up in 8 to 12 weeks with symptoms, spirometry, IgE and radiology. If there is response and patient is stable for 6 months, then it is remission. If there is exacerbation, we have to do oral corticosteroid and itraconazole like for months. If there is frequent exacerbation, then we have to add both. And if the patient is treatment dependent, we cannot reduce the dose of itraconazole or steroid, then adarazole, biological agents, nebulized amphotericin, low dose corticosteroids, they are the option for ABPA management. So this is short in summary for this ABPA treatment recommendation by Isham team. So for further details, you can go to the website. Thank you for your patient listening.